Very good morning. Our Honorable Chairperson, Dr. M.L. Swarkar sir, Pro-Vice Chancellor, Dr. V.K. Kapoor sir, Dr. Sudhir Sachdeva sir, Dr. G.N. Saxena sir, Dr. Hemant Malhotra sir, Medical Director, Dr. S.S. Jaiswal sir, all professors, faculty and residents. I am Dr. Sunil Kumar Agarwal, Professor and Head, Department of Interventional Radiology. Today, the Department of Interventional Radiology is going to present this CCR. But before we start the CCR, I want to present a brief introduction about the Department of Interventional Radiology. Interventional Radiology Department was established in this institute in year 2018, and in 2022, the two residents of the DM Interventional Radiology was admitted. And I am happy to say that this is our institute is the first institute in Northern India where the DM course of the Interventional Radiology was started. At present, there is 4 DM students in our department. Regarding the faculty, we are the 5 faculty at present, 1 professor, 1 associate professor, and 3 assistant professor, 4 residents, 2 second year and 2 first year. Regarding the work in the Department of Interventional Radiology, we are doing all the diagnostic and therapeutic procedures, and the common procedures which we are doing are the percutaneous transhepatic bleeding drainage, transhepatic intrajugular post-systematic photosystematic shunt, that is known as very commonly TIPS. The transarterial immobilization and transarterial reembolization, these are commonly used in hepatocellular carcinoma and also in various other type of the carcinoma. Uterine arterial embolization is sclerotherapy, which is used in venous malformation and into the varicose veins. Fistulography, PEC line, permacath, very commonly used, and the peripheral angioplasty and stenting. Regarding the departmental statistics, we are doing around 25 to 35 OPD procedures per day. These OPD procedures include the FNACs, that is the fine needle aspiration cytology and biopsy, under the guidance of USG and CT, and percutaneous drainage, that is the pleural aspiration, ascitic aspiration, liver abscess drainage, any cyst wherever it is present, or the cystic lesion drainage, or any type of drainage. The cath lab procedure is done 2 to 3 per day. This is the vascular procedures we do. About the statistics in 2023, about total number of the cases OPD procedure was done 3,504, which includes OPD and IPD procedures. And total cath lab cases in 2023 was 594. About 70 papers were published by the department faculty in various national and international journals. Regarding the academic activity, the department this national conference was held of the Interventional Radiology under the banner of Indian Society of Vascular Interventional Radiology in 2024 from 11 to 14 January. And the department took a very key role in this conference as a host in organizing this conference. And the department, the various faculty also presented the paper in this conference. Another conference, that is the EBT, was held in 2021, and this conference was organized by the department and into the Mahatma Gandhi Hospital. There about 250 delegates presented this conference. Our department is continuously involved in presenting the various papers, various lectures, and also conducting the workshop at the state level, at the national level, and the international level. And in this regard, a paper was presented by the faculty, Dr. Nikhil, in International Conference of the Interventional Radiology in Nepal in 2023. The other achievement of the department, lecture was presented by the faculty in endophyticon in MGH in Jaipur, and another lecture was presented in a national conference in January 2022 in Goa, and by our faculty, by Dr. Ira, our faculty lecture was presented in Soma Summit in July 2022. This was the National Conference of the Sonography. Another, as I told that, lot of workshop was conducted by the department in this regard. A workshop was conducted by the department in C.K. Birla Hospital, Delhi, workshop at December 2021, and into the National Conference of the Pediatric Radiology under the banner of Indian Society of Pediatric Radiology in April 2020. A paper was presented by Dr. Hira in Potential Intervention Technique Conference in 2023. Our residents are also very much involved into the academics internationally, and in this regard, a poster was presented by our second year resident, Dr. Rakesh Mehra, into the PAN Conference of the Interventional Radiology in Dubai in 2024. We have conducted various workshops in the various medical colleges in the state. That is, this is the conference. This is the workshop was conducted in Kota Medical College in November 2022, in Bikaner Medical College in January 2023, and in Jaipur Medical College in August 2023. Our infrastructure of the department is the procedure room. We are doing all the procedures there, and the cath lab where we do all the vascular procedures. The department activities done, the daily activities done. On the Monday, we are doing the case presentation. On the Tuesday, we present a lecture related to the resident of radiology, and all the radiology resident and faculty attend this lecture. Thursday, we conduct the journal club. Friday, we conduct the seminar. And Saturday, we conduct the group discussion. This is the list of publication which we published into the national and international journals. Now we start the today's CCR, an interesting case, a case of RTA road traffic accident with Dyspnea, and I call upon Dr. Avniendra Bharadwaja. He will start this CCR. Dr. Avniendra Bharadwaja, please.
Good morning, everyone. I am Dr. Avniendra Bharadwaja, first year resident from the Department of Emergency Medicine. So, a 51-year-old male, ex-army man, resident of Bharatpur, with an alleged history of road traffic accident in which his bike slipped on the gravel road on the morning of 25th February, consulted a local doctor and got treatment and was discharged the same day. In the evening, he experienced chest pain, difficulty in breathing, and restricted shoulder movement of the right side. He revisited the local doctor and got admitted there. But the next day, he was referred to a higher center. He presented to our emergency department on the next day, that is on 26th February evening, with the same complaints of chest pain, difficulty in breathing, and restricted shoulder movement of right side. His vitals were taken, which can be seen, and saturation of his saturation was 100% on high flow oxygen at 15 liters. So, according to this, he was triaged as red, according to the complaints and the vitals. So that we did not remove we tapered down the oxygen. We did not completely remove the oxygen. So immediately primary survey was done according to the ATLS protocol, which is Advanced Trauma Life Support. His airway was patent with no cervical tenderness. His bilateral air entry was reduced with a respiratory rate of 20, and saturation we tapered down to 95% on 5 liter oxygen on plain mask. His BP and pulse were, as I mentioned earlier, and a large IV bore cannula was taken on the left forearm as he had restricted shoulder movement and pain in the right side. He had no neurological deficit and pupils were 3 mm reactive to light bilaterally. Normal pressure was maintained and swelling and redness in the right clavicular region was noted. So, according to the data we have and the complaints, what could be the possible injuries in this patient? Can anyone in the audience please tell your answers? Alright. So, first of all, very common fractures. Pneumothorax, hemothorax, any solid organ injury, or blunt cardiac, aortic, or esophageal trauma. So, how did we in our emergency department ruled out and came to a diagnosis? This will be explained further. So, to help us establish a diagnosis, we did our primary survey, and these are the adjuncts. First of all, an X-ray was done, chest X-ray was done. So this X-ray was not up to the standards, but still we could see right side multiple rib fractures along with a large bulla. This is the large bulla over the left side. Yes, sir. Next, we did a shoulder X-ray, which showed lateral third clavicle fracture. ECG had normal sinus rhythm. Other adjuncts included ABG and EFAST, which stands for Extended Focus Assessment Sonography in Trauma, which was negative. So, since the X-ray quality was not up to the standards, and he had, and on the basis of the findings in the on the clinical findings, we ordered an HRCT chest. In this, we could appreciate a right side pneumothorax with a large bulla on the left side. So, what did we do? We gave the patient an analgesic, put him in oxygen support, and inserted a right ICD. This was the X-ray taken after putting the ICD in the emergency department. Here we can appreciate the tube going in. After all this, the patient was shifted to ICU after taking an orthopedics opinion with a total length of stay in emergency of 2 hours. Now further, the ICU management will be explained by Dr. Mohit sir.
Can you please go back to the CT system?
Thank you. Patient was received from ER in ICU. 51-year-old ex-army man with a history of RTU with right side pneumothorax with ICD tube inserting on right side, with multiple rib fractures and fracture of distal end of right leg. Brief history and physical examination from head to toe was done. Brief history and physical examination from head to toe was done in ICU. HRCT test which was done reported with dilatation of aorta, for which CT angiogram of aorta was done, which was suggestive of tennis ball sign. Can anyone tell what this sign is significant for? This is suggestive of aortic dissection.
One more finding of the
Sorry, sir.
another finding.
Some more findings.
At least one more finding. Another finding.
Fusion. There is fusion. There is ICD. You can make.
Yes, sir. ICD is yes.
Pericardial fluid also.
There is 2 steps for managing aortic dissection. First is stabilization and resuscitation. Second is planning and intervention. For resuscitation and stabilization, large IV or cannula access was done. Initially, acute treatment is done with medical management by control of blood pressure and anesthesia. Invasive blood pressure monitoring was done. Targets to achieve a saturation of 95 were achieved with oxygen of 1 to 2 liters per minute with nasal cannula. Hemoglobin more than 12 grams per dl with CBC monitoring. Systolic blood pressure was maintained 100 to 120 mmHg with beta blocker and vasodilators, and heart rate of 60 to 80 per minute with anesthesia and beta blockers. For this multidisciplinary approach was used. Many departments were involved with critical care, like pulmonology, orthopedics, anesthesia, CDVS, and interventional radiology. Later, interventional radiology planned for Jaipur. Now, I would like to call Dr. Neeshnat for further discussion.
Good morning, everyone. My name is Dr. Neeshnat N. I am first year DM resident in Interventional Radiology department. So the patient was referred to us for the aortic dissection. It was a case of left-sided large pulmonary bulla and pneumothorax on the right side, and there was a thoracic aortic dissection, that is Stanford type B. So in this case, this is the CT angiogram which we have been provided with. These are the CT axial image in which you can see there is a dissection flap with the true lumen and the false lumen, which can be well visualized. These are also the CT angio axial image which is showing the intimal flap for the dissection. The first image is the CT coronal image which is showing the extension of the dissection. This is the CT sagittal image, which is showing the extension of dissection from the distal end of the left subclavian artery extending to the abdominal aorta. This is the 3D reformatted image of the descending thoracic aorta, in which we can well visualize the starting and the end point. So this is the detailed diagram which we needed for the pre-planning and execution of our thoracic TEVAR procedure. We plan any aortic case in such a way only. So this is the 3D image with the measurement of our patient's aorta. Our main aim is to seal the entry point. The extension of the dissection starts from the left subclavian artery till the bifurcation of the aorta. The maximum diameter of the dissection is 4.9 centimeter. The distance between the left common carotid artery and left subclavian artery is 4 mm. Actually, in majority of the cases, the distance between these two spaces is 10 to 15 mm. But in our case, it was 4 mm, which was very difficult for us to angulate and to negotiate our stent in that zone. So these are few other measurements that are important for sizing and planning of the stent. So for planning, the distribution of the landing zone of the TEVAR is very important, according to which we strategize and execute our plan how to proceed further for the placement of the device in the particular zone. In our case, it was zone 2. If the case comes under the zone 0 and zone 1, we will be doing the debranching procedure. This is the animation which tells us about the formation and treatment of the dissection. As you can see, due to the high pressure changes and the exploratory changes, or maybe due to because of the trauma, the entry point, there is resultant formation of the flap and the descending aortic dissection can also be done. This is the treatment. In our case, we have used the femoral artery access, through which the true lumen has been cannulated with the help of guide wire and catheter. Now we are negotiating the guide wire. Now, once we confirm that we are in a correct position, we deploy our stent. This is the hardware device which we are using. It is a Zenith TX2 endovascular graft. It is a self-expanding metallic stent frame which is covered by impermeable fabric. So what were our challenges? Firstly, in majority of the cases, the landing zone is 10 to 15 mm, as I have already told. But in our case, it was only 4 mm. And it is a type 3 arch, which is more angulated arch, due to which there is a high chances of endoleak. So we have to be very precise while deploying the stent graft. And true lumen was also smaller than the false lumen, which make it difficult for us to negotiate the stent graft. So this is 200 mm in length, with the proximal end diameter is 28 mm and the distal end diameter is 36 mm. In our case, the aorta of our case, of our patient's case, so that is 32 mm. This is the digital subtraction angiogram video showing the vertebral artery shoot to know the cerebellar circulation of the contralateral side and the ipsilateral side also. So for that, we took the right atrial artery shoot and part our stent in the right brachiocephalic artery. The angiogram revealed that it is showing the good flow in the right subclavian artery and the right vertebral artery. Here we can see how the guide wire was negotiated in the proximal descending aorta. Usually the guide wire moves from left to right, but in our case, due to angulation, it was moving from right to left. Here we can see that we have placed the stiff wire into the descending aorta through true lumen and then negotiating the stent assembly device, in which we have to be very precise because lumen is small and the aortic wall is also feeble. This is the pre-deployment angio, which is showing positioning of the tip of a graft and also confirmed our position in the true lumen with the patency of all the branches. Now we are deploying and releasing the stent graft in the true lumen. Through the left brachial artery axis, we have cannulated the left brachial artery and brought the sheet to the desired position and plugged it. And took the shoot which shows no flow from the left subclavian artery into the aorta, that is, there is no endoleak. So here we can see and confirm that there is no endoleak. And now for plugging the left subclavian artery to prevent further chances of endoleak.
Doctor, do you have something like ultrasound on the tip to confirm that there is no leak endometrial? Leak from between the intima and
Yes, sir. The sonography could be done to detect.
At the end,
When the deployment of the plug across the proximal left subclavian artery, TSA was done, which revealed retrograde flow filling and reconstitution of the left subclavian artery, that is through the right vertebral artery, through the still phenomena, as just Mr. said. And there was no any endoleak can be seen. Now I would like to call upon the stage Dr. Vibhasa for the discussion regarding the challenges in the anesthesia.
Good morning everyone. I am Dr. Vibhasa Raina, second year resident from Department of Anaesthesia. I am here to talk about the anesthetic challenges that we faced while dealing with this case. Our two main challenges were Stanford type B aortic dissection and giant left lung bulla. The aortic dissection presented with life-threatening hemodynamic instability coupled with extreme sympathetic overactivity. We were also prepared to deal with complications involving extension of dissection, myocardial ischemia, and compromised distal organ perfusion. In giant left lung bulla, keeping low airway pressure ventilation was a key concern, as this could lead to rupture of the bulla, which could further lead to the risk of pneumothorax, pneumopericardium, and ultimately hypoxemia. Moreover, it was a NORA procedure, which is non-operating room anesthesia, so we had to work in unfavorable and unfamiliar environment without proper anesthetic aid. A thorough pre-anesthetic checkup was done, keeping ASA grade, NYHA status, comorbidities, med score, hemodynamic status, distal organ perfusion, urine output, neurological assessment, and pain and sympathetic activity in mind. Sir, ASA stands for American Society of Anesthesiology. It is a grading, sir. Basically, it is a predictor of the operative risk of the patient. So it's a grading from 1 to 5, and we categorize the patient based on their ASA status as a marker of their perioperative risk.
NYHA?
So NYHA is New York Heart Association. So it's a grading of dyspnea. Anesthesia management. Induction plan. General anesthesia was administered to the patient. Prime emphasis was to maintain a hemodynamically stable and smooth induction with an intubation time of less than 15 seconds to obtain the sympathetic stress response. One size small cuffed oral endotracheal tube was used in case of endobronchial intubation if the bulla ruptured intraoperatively. Low pressure IPPV was given. Maintenance of anesthesia was done using propofol and atracurium infusion. Tidal volume was set as 6 ml per kg of ideal body weight. IE ratio, that is inspiration to expiration ratio, was maintained as 1:2 to prevent air trapping. ETCO2 was maintained between 30 to 40 mm of Hg. No positive end expiratory pressure was given. Use of nitrous oxide was also avoided, as this could lead to rupture of the bulla. Maintain airway pressures less than 20 cm of water was done. Use of rapidly eliminating drugs and a volume restricted approach was adopted. Rescue plan. Now we were prepared with antiarrhythmics, ionotropes, initiation of ACLS protocol, and even cardiopulmonary bypass. In case of any complication like limb ischemia, mesenteric and organ perfusion, acute myocardial infarction, left ventricular dysfunction, shock. ABG monitoring was done both pre-operatively and post-operatively, along with intraoperative ABG monitoring. Blood products were kept ready for transfusion. Now a rescue plan if the giant lung bulla ruptured. We would have to go for one lung ventilation with right side endotracheal tube, endobronchial ETT, which would be confirmed by fiber optic bronchoscopy, and immediate left side chest tube insertion while ventilating the right lung, and shifting the patient for life-saving lobectomy to the CTVS-OT. Other options were use of double lumen tube and bronchial blocker. We extubated the patient on table after neurological assessment was done in order to prevent further positive pressure ventilation. Thank you. Now I'd like to call Dr. Neeshnat to continue further.
So, as the TR procedure was complete and the patient was extubated on table, then the patient was transferred to the ICU. After the 4 hours, the patient was allowed to take the sips of water on post-operative day, on that day only, and all the 4 limbs were warm, and the saturation was kept on 100% on oxygen support 2 liters per minute. And on post-operative day 1, the patient was mobilized without oxygen support. On day 2, the ICD was removed and the patient was shifted to the ward. On day 3, the routine care was taken care of, and on day 4 only, the patient was discharged on antihypertensive medications and antiplatelet. The vitals of the right upper limb on the blood pressure is 120 by 80 mm of mercury. The pulse was 110 beats per minute and saturation was 98%. Of the left upper limb, the blood pressure measures 98 by 74 mm of Hg. The pulse was 110 beats per minute and the saturation was 98%. So now for the further course of the patient, the imaging will be planned after 1, then 6 and then 12 months post-procedure. The patient will also follow up in the department of orthopedics and pulmonary medicine for clavicular fracture and rib fracture management and for pulmonary bulla. As of now, the patient is stable and doing well. These are some supportive articles representing that the left subclavian artery occlusion is considered safe and non-time consuming. This article represents that the TIVAR procedure is safe and all type B aortic stand for type B dissection should undergo TIVAR procedure, and it is superior to the open repair. It is taken from the Journal of Thoracic and Cardiovascular Surgery, JTCBS. This article represents that the TIVAR procedure is safe and effective alternative to the open repair. Thank you all for your kind information. Now I would like to call upon the stage Dr. Nikhil Bansal sir to give the vote of thanks to everyone. Thank you.
Type A dissection starts from the ascending aorta, sir. So basically repairing it is taking a very small area to open up, sir. And coronary branches are also arising from the ascending aorta, so it will be very difficult to repair with the endovascular technique, sir. In our case, it was a type B. As you can see, the extent of the disease is starting from the subclavian and extending to the bifurcation. So it will be very challenging for the CTVS surgeon to open up from starting from the thorax till the abdomen, sir. So if we talk about the post-operative recovery phase as compared to the endovascular repair is a faster recovery. What we can do is instead of taking a challenge of a 4 mm, there is a different technique which can be done. Like if the patient comes in a zone 0, zone 1, then the debranching, they will actually cut the subclavian artery, the origin of the subclavian artery or the carotid artery, and they will relocate those branches into the ascending aorta, sir. So in this case, definitely the debranching can be done, sir, but maybe we have done a few of the cases, so we are a little bit confident about it that we can able to manage that 4 mm size. We have a backup plan also. Even if we seal the left carotid artery, we'll put a stent across the device and make a chimney out of it, sir. So we are prepared with our errors also, that what if we occlude the left carotid artery, what if we are not able to seal the left subclavian artery, we are available with both the devices, sir, at that time, sir.
Whatever little I remember of cardiac surgery, that in
Dissection
surgically you have to deal only with the proximal part.
Yes,
distal part doesn't matter.
Yes, sir. Agreed,
So
sir.
your point that you will have to go into the abdomen probably is not.
Yes, sir.
But I think wherever non-surgically you can achieve equally effective and results, that would be far more preferable to surgery.
Yeah, that point.
See, when you talked about the Barber phenomenon today, how many triple bypasses are you doing? GJ and cholecystostetinostomy and jejunotogenostomy. It's no longer being done because a biliary stent takes care of these things within half an hour. So I think if it is Devar is feasible, that should be the procedure of choice.
4 mm gap I was
Yes,
asking.
no, sir. The option remains for the debranching of that particular branch. Then it will become a very easy for us. But the patient also not very much willing. Like then he'll become confused about whether to go for an open surgery. Then why not go directly repair the complete arch only, sir. So I would like to thank the all the audience, and it is always a teamwork with the collaborative effort of everyone. We are able to manage such a difficult cases. On the behalf of Interventional Radiology, I would like to I am very thankful for the management for providing such a beautiful space, and we have currently having a 3 cath lab and currently having all the devices which will be needed to manage these kind of difficult cases, and with the help of a collaborative department like Anaesthesia, CTVS department, we can able to achieve almost, and we can go beyond our limitations also. So I would like to thank the management for giving us the opportunity, and CCR review committee for correcting our mistake, and thanks to our collaborative department, Department of Emergency Medicine, Department of Critical Care, Department of CTVS, Anesthesiology, Orthopedics and Pulmonary Medicine. Thank you.